So it's going to be induction maintenance, more or less. I'm going to take you out of your comfort zone because here resistance is going to play a role in my case. So this is are my disclosures. And this is my patient. Had syphilis in 76, oral candidiasis in 94, surgery for gastric perforation in 98, recurrent genital herpes, and prior smoker until 95. So he was diagnosed with HIV in 93, so we are talking here about a 23 years history. He was 40 when he was diagnosed, so now he's 63, heterosexual, no hepatitis, co-infections. So in June 96, we started him on ACT-DDI. We didn't have a viral load. CD4 cell count was 328. 1 year later, he was switched to ACT and DDC. So resistant testing while still receiving ACT and DDC was performed. The genotype showed 41L, 67N, 70R, 215F, 219Q, or K65R, 210W. You can vote. So who voted for the first? For the one. So I'm going to wait until everybody votes. So who voted for the second? I mean, this is for a...
This is directly related to age. You have to be true.
You have to be old. So K65R with thymidine analogs. Who votes for that? Nobody. Okay. So this is a clinical care options that tells you what happens, a slide that tells you what happens when you use ACT or D4T. For unknown factors, you can go for these two ways, 41L, 210W, or 215, or 6570 or 290. So Jonathan, my virus didn't look at this slide because have everything. What happened?
Just one comment. We know some of the factors why we go one or the other, but go on. Listen, we don't know, actually, clinical care option doesn't, but we do know sometimes why you push one way or the other. But I think, Jose, the point you're making is that by looking at treatment history, we can guess a lot about mutations, and that's probably a crucial point here without even doing the test.
Also, they're not absolute. If you look at Brandon's first publication in '89 in Science, there were a lot that had 4 or 5. So eventually, if you let virus fail long enough under ACT, the patterns disappear and you get all 5 of them.
So we left this patient failing for a while. So I think we got all these terms. So we have this patient that has all these terms. So I'm not Jonathan, I'm not Charles. I have to go to the Stanford HIV database. I put all the mutations, and you can see here there is high-level resistance to all nucleoside except 3TC and FTC that he has not been exposed to. So it's still fully sensitive to FTC and 3TC. So in May, so we have these mutations in May 2005 with with a CD4 cell count of 756. This is interesting because despite being only with one nucleoside, there were a nice CD4 cell response and a viral load of 38,000. So treatment was switched to what? And please remember, we're in May 2005. And we have here, since 2001 TDF, we have T20, we have atazanavir, FTC, fosmanprenavir, antipranavir. So I have put multiple choice questions because we only have green and red. So who will go for green? Green is less drugs. So what will you do with this patient? Treatment interruption. This is a patient who's failing. So treatment interruption, waiting for better things than antipranavir or things like that. TDF monotherapy to maintain decreased fitness. This will be less drugs. Or you really go for the active approach and you go for lopinavir, ritonavir, FTC, T20, triple therapy, all of them fully active. Lopinavir, FTC, efavirenz, all of them fully active. Or Truvada, atazanavir, ritonavir, you were predicting things about 3TC. So who will go for less drugs? Treatment interruption, please place yourself in 2005, okay? Less drugs. So Pedro, you're...
No, the colors are confusing.
The colors are confusing. Yeah, forget about yes or pro. Yeah, it's green, you mean less drugs. Okay. Green, less drugs. Or red is just you want to go for undetectability. Okay, so overwhelming red. So what will you put this patient on, Andrea, in 2005? Truvada at that time. So it will be dual therapy. Tenofovir is not working.
Well, I don't think it's not working at all.
You think it's despite
because
the
there is not 210 and there is 215F. I think it's working a little bit.
So despite we're clinicians, despite the stuff,
well,
high level resistance.
Yeah.
So we'll work.
I think there's residual activity.
So Linus, what will you pick?
It's before START, before SMART, and all guidelines were then saying that above 500 we should not treat. So I would wait for better drugs.
And SMART were patients who were suppressed, right?
Yeah, but it's also before. Yeah.
Yeah.
Yeah, but even then, I mean, at that time, I think many clinicians would have stopped.
You will use less. You will interrupt, is what you're saying. So, Dr.
Not now,
Soto,
but
would you
at that time.
do?
I'll go for
Truvada, Tazanavir, Ritonavir. And the big with T20, Jonathan.
Yeah, I probably, in honesty, I wouldn't have given efavirenz with Kaletra. The interaction, the doses, the toxicity, that wouldn't have been. And I'd consider a Tazanavir, Ritonavir too weak to give with the with the resistance. So of the choices you give here, in honesty, I would probably tell the patient, listen, we'll start with T20. And if in a few months you're having a problem and you're undetectable, we'll pull it. And I'd probably go also with Truvada as opposed to FTC and go with the Kaletra.
So we go from treatment interruption to T20. So
yeah, I think just Jose, just for education purposes, but really I think you're on a the problem is here, can you build a regimen which is going to be fully suppressive or not, right?
Yeah, you can.
And then you should, because anything not being fully suppressive is just building up more problems.
But I agree with Liner. This is 2005, and the patient has almost 800 CD4s. The start has not been done, and there were many people who thought the treatment. And we know that T20 was not easy for a guy with 800 CD. I think I've never given T20 to a person for 3 months with 800. Lopinavir efavirenz is a... Okay. So what I did, I switched him to TDF monotherapy with the idea, I'm a clinician, so I got the idea, having mutations is bad for fitness. And, you remember the MX184B trial that maintaining 184B, slow down the decrease of CD4 cells. But with TAMs, if you do in vitro, actually the TAMs that this patient had really compromised very little fitness. But also, you see here, the one that compromised it most, it was 41L, 80%. So, but it's also, was the time when Steve Dix did these studies of discontinuing therapies in patients who have mutations. So I wanted to maintain, this can be criticized, but I wanted to maintain the mutations. And I kept TDF ongoing just to maintain the mutations and try to buy some time for better drugs than we had. So we remained on TDF monotherapy from 4 years, actually. When he reached a CD4 cell count of 360 and a viral load of 8,000, we do a new genotype, and the genotype is identical except T69N. That doesn't add much, right? So you put here T69N, doesn't add much. So, but now you are close to 360, 350 that we were.
But Jose, I mean, you can enter mutations into an algorithm, but you can also look at your patient. So how relevant is the prediction if you see a continuous decline on your regimen?
Yeah, right? That's why we are going to switch the regimen.
Sure. Okay.
So that's 360.
There are few times we actually have resistance which is based on data. But for tenofovir, Gilead was the first company when they came to the FDA to actually bring very good resistance data. That was the first drug that you could actually look in the label because the company had done the resistance before as opposed to after. And actually, the combination of having both the 41 and the 210, if you remember, so this is a little bit more driven. So
it was actually 3 mutations, either containing the 41 or the 210, which was a predictor of hardly any response, right?
Yeah. So, I mean, it's hard to also know because the 8,000 could be a very large reduction in some patients and could be a less than the other. But the bottom line is he stayed alive for 4 years without any clinical disease, so I guess that was the benefit.
Okay, so it's been 4 years on TDF, and now you have almost the same mutation. Now you have to design the induction regimen that now we're in 2009, and you have here darunavir, you have maraviroc, raltegravir, etravirine. So green, those who will use less drugs again, green will be Truvada, atazanavir, ritonavir, or red, more drugs that you have here, very active regimens with FTC, atazanavir. Well, you are voting already, so everybody goes. Is there anyone who votes for green? They're Rocío from my unit. Thanks, Rocío. Okay, thank you. So, who wants to say about among the reds? What will you pick? You're more raltegravir, darunavir, etravirine, duet type of what?
Three will work, but the second and the third is probably better tolerated.
Second and third. So, Pedro, do you think atazanavir, ritonavir, Truvada, based on GARDEL, will work? No.
I think it would be a risky regimen because you have lost tenofovir, and if you're not completely suppressive, you will very soon select M184B. So probably with the type of drugs that you are showing there, I would go for the trio regimen. That means darunavir, ritonavir, raltegravir plus etravirine.
Okay. So you don't think a fully active boosted PI like atazanavir, ritonavir, and FTC will work in a patient with a viral load of 8,000?
Well, not with the history of this particular patient. If you're talking about the patient that is okay and just fails for the first time without prior resistance, without prior exposure to other drugs, okay. But this patient, I wouldn't be confident on use.
So, Jonathan.
The question is how much we have to do evidence-based medicine.
Right.
So, I mean, I'm looking at the year, and as Pedro said, we actually had some studies that had been done by this time. So I'm not sure we should be designing the regimens just based on our hunches. For example, tizanavir, ritonavir, raltegravir was not a proven regimen at all in 2007. Whereas we did have studies which had supported darunavir, etravirine. We had great studies. Those were like landmark studies. Then we had studies that supported adding raltegravir to that. So I think I would actually put down the regimens where there was good clinical data. It was actually in the label of the drugs, approved by the FDA. I'm not sure why we would be designing a regimen that's not based on those beautiful clinical trials.
Right, but be kind to me. Because be kind to me.
In Spain, in Spain, I don't know.
I think there is not. I picked this patient because it is very hard to find a patient that was fully sensitive to 3TC and FTC, and fully sensitive to a boosted PI. We've been talking a lot about 3TC. Has compromise of the others. So, but you were saying minutes ago that who was saying that 3TC was a very potent drug?
But it wasn't proven.
Who was saying that?
But it wasn't proven. I mean, I do think.
But there are minds that look.
No, I just think a little bit in HIV we too much use our own creativity, and in other fields of medicine you always have to do what the clinical trials show. And somehow, these are all good regimens, but I think Pedro was saying, at that time, we were all so happy about the trio. We were, very happy to do it, but you're right.
This is not a trio type of patient, right? He has compromise on, he has fully active PIs, fully active 3TC, fully active non-nucleosides. So.
Well, we could argue about it. Anyway.
Okay. So be kind to me because I put the patient into bad atazanavir, ritonavir. Okay? And I got lucky because, well, and I put here GARDEL, just to say that a fully active boosted PI and a fully active 3TC, even in patients with high viral loads, seems. Well, I was waiting for that comment, because when you have all this, why Stanford database says fully active, but you are explain why it's not 3TC fully active, Andrea. Yes, you're right. Low-level resistance, you're right. Because the mutations also, okay, you're right.
What was the cause of the low-level resistance to 3TC?
Multiple times.
But that was an old interpretation of Stanford, wasn't it?
No, actually.
Still?
So.
Bob Schaefer has, you gotta watch it, because if you click on it, there actually you do get a phenotypic. Without going to too large a detail, we don't know the clinical correlates of phenotypic susceptibility to 3TC and FTC. Because usually, as Jose says, it's 184 game over. So it's hard to know the dynamic range of 3TC. When is a phenotype enough to give you a change? So if you look at, and they're hard to find, but if you do in your laboratory multiple TAMs, a full TAM pattern to 3TC, you see the phenotype move. You see the susceptibility reduced. The question is that enough to compromise the clinical activity? We don't have clinical correlates. So although, if Bob were here, he could give a whole talk on that. It is not the same as a patient who has a drug naive. We considered it low level, but but it does have a phenotypic impact. The question is how clinically relevant it is.
Yeah, that's a good. So I had the slide, but I didn't put it. When you have multiple TAMs, it seems like, well, I got lucky. The patient wasn't doing very well from March 2009 to September 2009. He got undetectable. CD4 went up to 558, viral load less than 50. And in September 2009, I was not in the unit. Another doctor sees the patient and asks why this patient is on TDF if genotype confers high-level resistance. So, new doctor doesn't even think to change a regimen prescribed by Dr. Arribas, or new doctor couldn't care less and changes regimen. That's it. So, obviously the regimen was switched to FTC, atazanavir, ritonavir, okay? So, again, Andrea is going to tell me that FTC, this is not the appropriate comparison because this is the SALT study. Patients who are suppressed in triple drugs, they have this running phase. They switch to 2 nucleosides and atazanavir, ritonavir, and they optimize the nucleosides, and then they randomize to atazanavir, ritonavir, 3TC, dual therapy or continuation of atazanavir, ritonavir, and 2 nucleosides. And you've seen the 96-week results have been recently presented. The take-home message is when in this type of population that I've recognized is not the same that my patient, because it might have some resistance to 3TC, this combination did very well. So the patient stays on FTC, atazanavir, ritonavir. The patient keeps doing well for 5 years on FTC, atazanavir, ritonavir. On November 2014, with a CD4 cell count of 932 and a viral load of 50, starts treatment with omeprazole. This is what Pedro was saying. It's one of the reasons to switch therapies. So what will you use? Will you use 3TC, lopinavir, ritonavir that you have the OLED data, or you use darunavir, FTC? We don't have still those data. With OLE, we have, again, the results of being published. Basically, Pedro already commented on this. It's another switch study in which patients who are suppressed on lopinavir, ritonavir, and 2 nucleosides were randomized to continue or to switch the 2 nucleosides to 3TC. Again, we saw non-inferiority, same level. No matter how you look at the data, virologic failure blips or virologic failure of any blips, when you add 3TC, the issue we have with monotherapy goes away. You don't see those low-level viral rebounds. And with darunavir 3TC, there is no data, but you are going to see on Thursday the results of dual. The title is self-explanatory. It's non-inferiority of dual therapy with darunavir 3TC versus darunavir and Truvada or Kyvexa. So who will use, with omeprazole, who will use FTC lopinavir and who will use FTC darunavir ritonavir? Even before seeing the results of the trial, right? So this is not exactly evidence-based. Maybe that's why Jonathan is still on green. Okay. So regimen switched to FTC darunavir ritonavir. So patient doing well. So it still went from atazanavir ritonavir to darunavir ritonavir FTC until August last year. CD4 was 1,000, viral load 50. He's now, it's 2015, he's on 62. Angina, a cat so severe artery disease of 3 main vessels. He got 3 stents. This has a depressive anxious syndrome on follow-up by psychiatry. Chronic low back pain. All of a sudden, he's taking bisoprolol, nitroglycerin pads, aspirin, trazodone, clonazepam, gabapentin, atorvastatin. So for the pharmacologists, they've been very quiet because now is your time. Are you happy with Giovanni? Are you happy with darunavir, ritonavir, and all this polymedication?
We must be careful. I mean, there's a couple of items at least to take off or to better combine. Atorvastatin has to be changed, and then clonazepam, depending the dosage. Aspirin, okay. It's nitroglycerin. It was nitroglycerin.
Nitroglycerin, yeah.
Okay.
Nitro, yeah.
It's the explosive. Okay, so okay. No. Just it's a funny cocktail, actually. Yeah? So no, I mean everything has to be reviewed. I mean.
So you would like to get rid of ritonavir or cobicistat?
Possibly, yes.
Possibly.
I mean, yes.
So then we have a patient that is been on a fully active boosted PI and a almost active 3TC. So and it's polypharmacy, and you want to switch the regimen. You have to switch the regimen to something without ritonavir. So again, less drugs. Remember, this is a mutation on darunavir FTC. You can go for dolutegravir, rilpivirine, FTC dolutegravir, or 3TC dolutegravir, less drugs, or keeping non-nucleoside is left behind, and you TDF, FTC dolutegravir, or FTC dolutegravir, rilpivirine. That will be. So who will go for less drugs? Dual therapy with dolutegravir, rilpivirine, or dolutegravir FTC, and who will go for more drugs? So the first time I see less drugs winning here. So you, Pedro, why will you go for triple? Which one you will pick?
Well, probably I would pick number 4 because FTC is a very well-tolerated drug. It doesn't add that much complexity. And so far we have good data on dolutegravir rilpivirine, but I think it's too early to call this a good regimen in a patient that had such a complex history. FTC doesn't add you any issues regarding drug-drug interaction with all the medication the patient has. And I would feel more comfortable including FTC in the regimen. Albeit I recognize that probably with 2 drugs, particularly with regimen number 1, they should be okay, but I'm not sure about it.
What happened to us on that result? That's the question. Great question. Great question. He's still on omeprazole. I didn't put it, but it's true. But that's what happens in the clinic, Jonathan. You don't. Because the patient tells you the new medications and you keep forgetting about the gastric protector, that's what's called in Spanish. So what would you pick? You were saying. Yeah.
I work for ViiV, so I don't think it's fair.
No.
But I still take care of patients every week, right?
But all options have dolutegravir, so it's a neutral choice, right?
Something that doesn't have rilpivirine.
What?
Something that doesn't have rilpivirine.
Something that. Charles, what would you pick? No.
Anybody's guess, I guess.
So one point I think it's important, as you said, in the clinic it does happen. The patient doesn't consider the omeprazole a drug anymore, and he doesn't even mention it, and that probably happens a lot. I would mention that there is one key factor on this patient the entire time, which is that when he was on tenofovir alone for years, he had 8,000 copies.
Right.
And those patients do very well. And those who after 4 years on tenofovir alone have 150,000 don't do well. So I mean, I think Pedro, you alluded to that. You know, there are characteristics of this patient which are great. One, he takes his drugs very well.
He takes it very well.
He takes his drugs and he has a low baseline viral load. And I think that, you know, I just might argue with our clinical pharmacologists that they're a bit wimps. Because atorvastatin is not a big deal. You just give a lower dose and you save money. So, you know, we're not impressed. So if you guys want to make a big deal over there, let's have it out. You know, I think it's fine, and this patient will be fine with these. But I think, you know, you could argue, what's the deal breaker here that...
well, if you put all of them in the HIV Liverpool database, all of them appear as potential amber.
Yeah, but, you know, that's the Liverpool site. They just say, you know, amber, 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 and, you know... sue me, right? We know. It's like the Stanford database, you know, resistance. It's all crap. Anyway, I just, you know, I'm sure it's right, but I think there is a stage where you actually make a good decision here as a doc. And I think the omeprazole that Harold mentioned is a great point. These are fragile drugs, and that would be in the consideration. We might switch, but I think it's good to just say, oh, we're scared of interactions, let's get away from the boosted PI. You said this is a patient where, you know, we're concerned. We'd actually be happy for this patient, you know, to be on the boosted PI. Anyway, I just think it's a decision that is, we don't just take the drugs off when we have it. We look if we need to.
Yeah, this is the type of patient that makes me very nervous when they are on so many medications, Jonathan. They go to see many doctors. And I think for me, I have peace of mind if I have something that doesn't have interactions. And if I go to the Liverpool database and I see all those numbers together, and you see all these triple and quadruple, I don't know if interactions that I don't know if you want to comment, it makes me very nervous. But what you said is the art of switching. What you said is a patient who has been with 8,000 copies on TDF, those patients tend to do well. So I'm just to mention that these trials are ongoing, trials of dolutegravir, rilpivirine as a switch strategy. So I pick to switch to TDF, FTC, dolutegravir is what I switched to. So will it work? So we've seen, according to the GS score of the, they have presented this afternoon, and according to the dolutegravir monotherapy, will it work? What? Functional monotherapy. Functional monotherapy, well. So, will it work? Well. So, will it work better, TAF, FTC, dolutegravir, a virologist in the room? No? So, you need, Anna gave me this slide, and I'm very,
Do you think dolutegravir monotherapy wouldn't work in this patient? In this patient?
In this patient, dolutegravir monotherapy, I think if I have still 3DC, I wouldn't, you know.
Yeah,
I have rilpivirine, because the omeprazole, but I think
No, I think all the decisions are right, but I think in honesty, what we should remember is you know, we're talking about success of 90 versus 95, or 96 versus 88. You know, in all our studies, we're not willing for any patient to fail. But in honesty, you know, if this was Vegas, and I saw this patient, I said, okay, he's undetectable all this time, he has good, you know, good doctors, low baseline viral load. If this was Vegas, I'd say, give the patient dolutegravir monotherapy, I put my money that he's undetectable. It doesn't mean I'll do it, but I think that's important for us to, and I agree with you. If it's not a high...
Jonathan, you go from evidence-based medicine to Las Vegas.
Yeah. I think the evidence-based medicine here would be probably to try to keep a PI on board.
Yeah.
That would be the evidence-based medicine, to try to deal with them. So if we did have to do it, you could argue that this patient should stay on a PI, and we should see which of those drugs the patient actually needs, and which of them we can't handle the interaction if we're evidence-based. But I agree with you.
Yeah, right.
Yeah, I would never give this patient dolutegravir monotherapy because he has lost so many options. So yeah.
Lots of. Oh.
I mean, he has a lot of options lost in the past. So I would not risk monotherapy with dolutegravir.
So, and you have this COVID, you will prefer tough or not? Small thing. So we don't have. I think Dan was saying we don't have clinical data that in patients with TAMS, right? Tough. That's something. Andrea, you want to say something?
Frankly, I would have chosen dolutegravir 3TC or FTC because according to our experience, which was shown before, so most of the patients on this dual come from other dual therapies for tolerability issues or drug-drug interaction issues, so similar to this case. And in addition, Alberto was showing that about 15% of these patients have in their treatment history an M184V. And this, at this stage, does not seem to affect failure, but...
Okay. So, one more question.
One more
Not
minute.
question about his psychiatric symptoms and dolutegravir.
Sorry, what?
You said that.
Psychiatric. So
yes.
this guy, it's a great question actually, because it's with all the noise that there is about dolutegravir, and if you use dolutegravir in patients with psychiatric syndromes right now, I think, yeah, in this patient, I use it, but I understand that it's something that is unresolved. My personal take on that is that there are definitely patients that something happens when you give them dolutegravir. I've seen them. The thing is how frequent they are. It's a matter of debate. In my clinic, very few, but there are definitely patients that when you start dolutegravir, something happens CNS-wise. Okay.
José, we are having great discussion, but we are running out of time.
Very quick, I put him on dolutegravir.
Before I just give 1 second, because I think you have an interesting slide there, because the previous one, because you're suggesting here from the data that you could actually treat some of the tenofovir-resistant viruses with TAF. That's a theoretical principle, right?
Yeah, well, this is in vitro, and in
yes.
vitro, in vivo, I don't think nobody have shown that.
It's a very good point. I think it's great.
This is.
I think, as Jose says, this is not K65R.
Right.
And this would be a fantastic study to do because we're really not convinced, and we all feel that maybe you would have something with the TAF. I think it's a great point. And we don't have a lot of these patients who have the TAMs only, and it would be a good science question, Jose, you're right.
Okay, put the patient on dolutegravir. I saw him actually early this month. Viral load is less than 50, CD4 is 720, so we have this follow-up from August. I was putting here paddle because I always put paddle in all my presentations. Pedro, it's the most exciting pilot trial that we've seen in many years. So, and as we speak, we are enrolling patients on dolutegravir 3TC patients who are antiretroviral naive. So will you switch to FTC dolutegravir until those data are available? That's the last question. I have the patient still. So it's divided. So we have to wait. These are equipoise. We have to wait for the results of the trial. Thank you very much.